Several things on the, and everybody wants to present last, so we can't have that happen. So it's just going to be sort of whatever I decide and look at. But let's go with the Senate Resolution 413 first, and that would be Senator Orrock. Welcome back over to a House committee, Senator Orrock. House trained? Did you serve 20 years over here? And went to the lower house, I know.
That's right. Yeah. Everybody's got to do it one way or the other. But thank you very much, Madam Chair, and I appreciate the committee's result. This is a very, this is an urgent resolution, which would simply put us in this posture as a legislature. There we go. The audience was spared all those wisecracks at the beginning. This is an effort to send a message to Georgians to seriously engage with the opportunity to do your advanced directives, your health directives, and talk with your doctor, speak with your family. The sad statistic is that I think by the time you get to your early or mid-80s, half of those people who live that long will have dementia issues. There are a myriad of reasons why you would find yourself in a position to need an authorized representative to make your wishes known or to express them yourself through an advance directive. And that's what this simply urges Georgians and supports all the reasons why people need to strongly consider preparing for the eventuality that you will be in a medical situation and want to have your wishes honored. And it allows the physicians and the health providers to know how to proceed, and certainly your family as well. And I took this, Madam Chair, the state of Utah passed this resolution, and many of us that work on this issue thought that would be a good thing for us to continue to send the message. And a lot of legislators have worked on this issue, crafting the statutory language around the advanced directives and authorized, medical guardians. The hospitals are very pleased, already cooperate very fully in the nursing homes on making these advanced directives available. So I would appreciate the support of the committee. And
Okay, thank you. Senator, I do have one question. We have some people that feel pretty strongly against urging resolutions because they wonder what they really accomplish. And do you have plans? How is this going to be used to get the word out, rather than just passing and it goes into a file and,
Right. I worked with the Georgia Health Policy Center on this, and they have a form that they make available and work with the nursing homes, work with the hospitals, any place where the senior population appears in abundance, and with the medical community. And they helped craft this language and will work through the critical choices is the form that they have that they make available across the state, and they will make use of this resolution as they broaden their outreach to all those institutions.
Okay, thank you for that information, because that was something. We have questions from the committee. Representative Mitchell.
Well, actually, Madam Chair, I was just so overwhelmed with the Senator's presentation, and that she should be applauded for the great work she's doing for this state. And at the appropriate time, I'd like to make a motion do pass.
Okay, we'll do that. Are there any other questions for the committee? Senator, if this passes, who's carrying it on the House floor?
Well, I have two people that I've asked about it, and Stacey Evans and Mary Margaret Oliver. There's a companion piece that's a bill that Andy Welch is carrying, and he may choose to do this one as well.
Pick a name.
Andy Welch.
Okay, there we go. Good choice.
How's that pick?
That's a great choice. If he's carrying the companion one, that's a good choice. Okay. We have one person that's signed up to speak on the bill, and that is Bill Baroff.
Bill Bozarth.
If you go to the podium and tell us your name again and who you're with.
Bill Bozarth, and I represent myself. I was one of the people that brought this idea to Senator Orlock, Senator Underman, and others in the Senate. And I do some work with an organization that tries to simply encourage people to have advance directives. Some of the statistics will say that 80 to 85% of the people in this country, when asked, say that they would like to die at home with their loved ones surrounding them. The sad statistic is over 80% of the people die in some sort of medical facility. So what this is really an ability to use the power of a legislative resolution to help us get out a message and encourage more people to take advantage of this opportunity. And that's really why I brought the bill to her, and I just wanted to thank you for consideration and urge the passage. Thank you.
Well, thank you for being an advocate for getting to people and letting their last wishes be honored. Thank you very much. That's the only person I have signed up. Anyone else? All right, don't have anybody else. Okay, Representative Mitchell, you are recognized for a motion.
Move to pass.
Okay, have a do pass. And second, thank you. Is there any further discussion, Representative Kaiser? No discussion. Everyone in the favor of the passage of Senate Resolution 413, that's LC 100-0326, say aye. Anyone opposed? No. Ayes have it. Thank you, Senator.
Thank you, members of the committee. Madam Chair.
I didn't. I take it Senator Carter's not here. Oh, you're ready. Senator Carter, Senate Bill 216. Welcome back to the Health Committee, Senator.
Thank you. Thank you, Madam Chair. Members of the committee, I bring before you today Senate Bill 216. We offered a sub up to this and gave you copies. I'm working off of LC 335210S.
Hang on just a second. Do we have it in our folders? Everybody except me? Okay, I got it. It's LC 335210S.
Yes, ma'am.
Has everybody got it? Pardon? Pardon? They've got it? Okay, I can hear. All right. Go ahead.
Thank you. There are two parts of this bill. First of all, in Section 1, you'll see that this changes on line 17 the fact that a licensed pharmacist is not physically present in a hospital. The hospital pharmacy is closed, and the licensed pharmacist will be physically present in the hospital pharmacy within 24 hours. We had changed that to 16 hours last year, and we're wanting to change it to 24 hours. As you're aware, there are a number of rural hospitals, smaller rural hospitals, that are struggling these days. In fact, we got notification this morning that there would be another one closing on Friday. I believe Stewart Webster Hospital in Richland is going to be closing its doors Friday. It closed its emergency room this past Tuesday. And in order to try to help with this situation without compromising patient safety, we're willing to make this, we want to make this 24 hours so that they won't have to have a pharmacist there physically until 24 hours from when a patient is admitted. On line 21 through 24, we've also added at least one licensed pharmacist is physically present in a hospital within this state, which remotely serves only on weekends, not more than 4 other hospitals under the same ownership or management, which have an average daily census of less than 12 acute patients. Remote order entry is a new practice that we have in pharmacy, whereby via computers, pharmacists are on call to review drug information and patient admissions for their drug therapy, whereas they will review for drug interactions, drug duplication, etc. This can be done, and what we're saying simply in 21 through 24, that as long as there is a licensed pharmacist present in the hub hospital, in the primary hospital, that if they have either management or ownership of 4 smaller hospitals that don't have a daily census of more than 12 acute patients, that they can use remote order entry in that situation. That is the first part of the bill. The second part of the bill, and the original intent of the bill, deals with emergency medical services. In the past, ambulance services, emergency medical services have been limited to having only one pharmacy provider. The reason for this, of course, was to make certain that the Board of Pharmacy was aware of who they were obtaining their medications from. Because of numerous instances of drug shortages here recently, it's become necessary for them to have more than one provider, and this simply changes to allow them to have more than one pharmacy provider, giving that perhaps if one provider is out of a certain medication, that another provider might have it in stock and they'd be able to get it from them. They still have to notify the Board of Pharmacy who they have the contracts with. And that's the two parts of the bill.
Well, thank you for bringing the bill. First of all, I have 4 questions. How many hospitals do we have in the state that have less than 12 acute? Is it?
Well, particularly in South Georgia, particularly in Southwest Georgia, we've got quite a few in the Valdosta and Albany areas. We've got quite a few that are just critical access hospitals that, we want them to stay open, particularly for their emergency room services, but we understand that they may not necessarily need a pharmacist at those times, and it can be served through the hub pharmacy.
So it's mainly in our rural areas where you find the
is.
small, which I think are usually the largest employers.
Yes,
in the
they are.
town,
In fact, the one that's closing this Friday is the largest employer in that county.
which makes it a real loss.
It does.
Thank you. Okay, we have questions from committee. Andy Welch? I mean, it's not Andy. Who are you talking about? Oh, sorry, I was going. Andy Welch is not on the committee. Okay. Representative Watson, sorry.
Thank you, Chairman. And to you, Senator Carter, I certainly appreciate you bringing the bill. Representative Jason Shaw from the Valdosta area, this has been a significant issue for him through his hospitals there in that area, and we certainly do appreciate you working with him on adding this 2-year bill, and hopefully that will help alleviate some issues, and specifically, exactly what you allude to is keeping the hospitals open. Just for everybody's information, critical access hospitals, federal designation, if I remember correctly, and different pay, the way they're paid, and it is to provide access to rural patients and to keep those hospitals in hopefully a little bit better financial shape. And this will go a small step towards helping with that also. Thank you.
Yes, sir. Thank you.
Representative Kidd.
Thank you, Madam Chairman. What does a hospital that's not owned by or a corporation that has 4, 5, 6 hospitals, what's the privately owned individual hospital with 12 beds do? They have to have a pharmacist 24/7 or available 24/7?
Well, then it would apply to them up on line 15 through 17. They would have to have a licensed pharmacist that's physically present, with the exception of within 24 hours. In other words, if they had a new admit, then they'd have to have a pharmacist there to review it within 24 hours.
So we're really treating the small pharmacy, independent hospital differently than we're treating the corporate-owned 4 hospitals.
Well, I understand. I see your point there, but this is to address a specific problem, an immediate problem.
I realize the problem, but it seems like we're providing assistance to hospitals that are corporately owned, if they have corporately owned the 4 hospitals, but the individual owned hospital that's still in existence would be adversely affected because they're having to hire somebody for 1 hospital, and the rest of them got somebody for 4 hospitals. Okay.
Okay. Representative Watson, you have another question?
Yeah, I'm not aware, Senator Carter, that there are any hospitals in that particular situation. Maybe Representative Kidd is, but most of the time these hospitals, because of economy of scale, will use other larger hospitals for management services, not just for pharmacy, but for management, and that's what this particular goes towards. So, I think this helps Representative Shaw in his area, and certainly if any other hospitals that are independent like that, I would think that those that are independent would have an average daily census a little bit larger, so that may be why that's not the case in other places.
And from our pharmacy contingents, Representative Harden.
Thank you, Madam Chair. I think Dr. Watson answered basically what I was going to say. I don't think you'll find many small rural hospitals with less than 12 daily census that are operational at all, so,
Okay.
individually.
Right. Representative Sharper.
Just speaking into Jason Shaw area, he's more into the Lakeland and Homerville area, in which I'm in Valdosta with South Georgia Medical Center, and this will help out a lot because, you know, being a paramedic for so long, and I see that in the smaller community, so this is something very needed, and I really appreciate you doing it. And also kind of to the west of us with the Archbold systems with Brooks County, all those little areas, this is really going to help them out a lot. So I really appreciate you. Thank you, Madam Chair.
That who? Representative Harden. Oh, you said. Okay. That's the last of the questions. Senator, thank you very much. I know that this bill was added on with an amendment, and I appreciate you working with the Hospital Association to take care of that again, since it does help the hospitals and one of our House members. Okay. What is the wishes of the committee? Oh, wait a minute. Wait. Got somebody who wants to speak about it. Sorry, in all this list, I missed Ethan James. Oh.
Is there any questions? Although I think all the questions were answered by various committee members.
Discussion, everyone in favor of the passage of Senate Bill 216 LC 335210S, say aye. Aye. Anyone opposed? No. The ayes have it. And who's carrying this bill?
Representative Chairman Alan Powell.
Okay.
He stepped out, yes. Thank you very much,
very much.
Madam Chair, members of the committee.
Thank you. Okay. We got, Senator Miller, you just walked in just at the right time. Senator Miller, come on up. You don't get to rest. Okay, let's go to, yes. Okay. Thank you. Okay. You can do the podium, or you can.
That's fine.
Sit. Okay. I think we have a substitute. This is a substitute to Senate Bill 94 that Senator Miller will be working off of. It will be LC 335207S. I will be. Okay. Ready to go?
Sure.
Has everybody got it? Substitute LC 335207S. Go.
Okay. Thank you, Madam Chair. Madam Chair and I have discussed the substitute to the original bill, which was originally going to allow advanced practice registered nurses to order MRIs, etc., under all circumstances, not limited to the emergency situation, which is in present law. The substitute that has been discussed, if you look on page 1, we've deleted the life-threatening wording there. You go to page 2, and again, we're still talking about protocols here, and the changes are as follows: that an advanced practice registered nurse cannot order these tests unless they've had at least 5 or more years of acceptable experiences as an APRN, okay, unless there is an emergency, life-threatening situation. Interestingly enough, we also limited it that you cannot do it for a child. When I say child, a person under the age of 18. I've had some conversations since this bill passed with the pediatric people. They have some major concerns about the amount of radiation that young people are getting. They came to us. This was added to the bill. And then another provision in here about they can't do it in these retail medical clinics, in supermarkets, etc. And again, these particular exams, when they're ordered, will go to a physician, go to the radiologist, of course, that read it, as well as the APNR. Section 2 takes these same provisions and amends what a physician assistant can do, and basically according to the same terms. Dr. Watson developed most of this particular substitute. I think he has tried to be fair in the scope of what we're doing here and the reasons for it. I think we have to be realistic that there are areas of this state where we do have a shortage, particular people that can do this type of work. That's one of the major reasons for it. And it basically puts the PAs, the physician assistants, and the advanced practice registered nurses on the same playing field. Dr. Watson, you can feel free to add to this, but I think that's pretty well a synopsis of what LC 335207S does.
Okay. Got it? Okay, questions, and we have Dr. Watson, you're up.
Thank you, Senator Miller. The bill as it was, I had several reservations, and I still do have reservations about increased radiation exposure. I mean, I think that's a real issue. The New England Journal about 3 years ago or so, raised that issue in particular. The more radiation exposure, especially with CAT scans, responsible for a certain percentage of lymphoma and leukemias, and that's you have to be careful. You got to balance, what's important and what's not. It's interesting that the radiologists, themselves, who would benefit by more tests being ordered, are sensitive to the radiation exposure and were against that. And in children especially, because those cells are turning over so fast and are more susceptible to radiation exposure, and so lifetime exposure. Actually, I'll tell you, the experience issue was something that I had been concerned about, both personally and professionally. And when I raised it to other physicians in the community who were actually for the bill, they agreed,
Sure.
and I think rightly so. The experience.
Well, anybody new is going to order more tests than somebody that's been around with experience. So I think that would be. I don't see how anybody could argue with that assumption on your part.
Right, and the question, I will tell you, I don't have data to show that. Does in states where advanced practical nurses or PAs are ordering them straight out of school, or if they've been given that new privilege, is there data to support that? I'm not sure whether any studies done on that. I have asked for those studies to be forwarded to me, and I have yet to get those, but so that may be the case that hadn't been done. What I felt was, what was fair for the goose was fair for the gander, relating to nurse practitioners and PAs,
right,
and delineation of privileges there. I think in good faith we've tried to work with this. I think Madam Chair may know, but I think we have several people that are to testify, or do we have a few?
Yes, we do.
We do. So I'll reserve any further comment with that. It's an issue that has been brewing for a while, and certainly you have to balance patient care versus the risk and benefits. So cost and so forth. It's a complicated issue. Thank you for bringing it, and I'm interested in hearing what's to be said. Thank you.
Representative Henson.
Michelle?
Thank you. Are we changing anything that physician assistants can currently do?
Yes, you're limiting the scope.
Why are we limiting the scope?
Well, I think Representative Watson tried to answer that question, because I think that in this particular instance, many in the medical community feel that these are parallel paths and they should be on an equal playing field.
I understand, and I can see that, but my question is, have we even consulted with the physician assistants? Are they even aware that all of a sudden we're dropping a bill that's limiting their scope?
Representative Hanson, I think there's been some discussions, but I got this substitute 30 minutes ago.
That's my point.
Now, but I do think that the chairman has had discussions with people, as well as your vice chairman, or else we wouldn't be sitting here with these options.
I understand, but do we have anyone that's representing physician assistants here in the room today?
Representative Henson, we do, and he does want to speak.
Okay, because I just have concerns with, are we having a problem with physician assistants currently doing what they're doing? That we're suddenly pulling back and limiting their scope?
Let me try to answer that for you. I think the question has been raised over the last couple of years. Do we have too many of these type of tests? That's the question. Not necessarily who's ordering them, but do we, in totality, have too many of these type of tests? I had the pediatric people come to see me purposely and say, look, we are really concerned about this as respects young people. And what Representative Watson has done in this bill is say, okay, we're not doing it for kids under 18 anymore. This is probably, I'll say, a relatively new development in the last couple of years where people are more and more concerned about not just defensive medicine, but the implications from a health perspective of how many of these dosages you can take. I certainly don't have that answer, but I think it's been a real concern. So I think this is something that's been brewing. Quite frankly, I think this bill gave people some opportunity to limit maybe what we've been doing in the past. Because remember, if it's let me finish.
Yeah.
If it's a life-threatening situation, they're going to do it. I've been in a life-threatening situation, okay, where they go in there and they shake you up about 3 different ways, okay? That's different. Everybody's still going to do that. This is in the non-life-threatening situations we're talking about here.
Okay, now, child falls, hit his head against a concrete driveway. Many cases for an adult or child, they're going to order is a CAT scan or an MRI to make sure and to double check. Now, here's my question. If the nearest hospital is far away and you've got something closer and it's for someone under the age of, is it 16, under the age of 18?
Representative Henson, I think that Senator Miller may just not be making it clear enough, but what he's trying to tell you is if the PA or the nurse practitioner decides that this could be a life-threatening situation, they may order the test at that point.
Okay, a concussion's considered life-threatening?
No, probably not.
But yet they order MRIs or CAT scans for that when they feel that there might be a threat.
That's part of the problem, is what people are thinking, is perhaps we're having too many of these tests. Look, if you go into a situation where they believe it is life-threatening, for example, when I had seizures, and they brought me in the hospital, they thought the first thing they're going to look for, they think it's a brain tumor. They're going to do, that's an emergency situation, even though I'm an adult at that time. If it was a kid, the same way. They may probably think it's life-threatening. They're going to do the test. The question is, and I guess what the medical community is saying, not Fran Miller, maybe Dr. Watson, his peer group, etc., say, are we doing too many of these tests based upon the studies that they're reading and seeing that we didn't see 5 years ago? I don't know how better to answer your question. I'm sorry.
I think my question is it the doctors, is it the physician assistants, or is it the advanced practice nurses? And that's my question. When I fell and hit my head against my driveway, I had an MRI, and it was ordered by the emergency room physician.
Okay.
So, I'm just questioning that. It's just something that's come across here very unexpectedly.
Representative Henson, I know you look like you're under 18, but this bill wouldn't apply to you. So, anyway, so if you hit your head again, they'll be able to, if it's an emergency situation, order it.
This isn't Fantasy Island, Madam Chair.
Pardon?
Nothing.
Okay. Representative Reiners, and you definitely look over 18.
Thank you, Madam Chair.
I'm teasing you.
Thank you, Madam Chair. Line 30, if you would, Senator.
Sure.
That acceptable experience. I have no clue of what acceptable experience is.
I think that's, these are people who are subject to the medical board, and if they're...
So they decide what's acceptable experience?
Yes, that's correct. Yes, I'm sorry, yes.
I'm sorry?
And the physician.
Keep in mind, too, from a standpoint, here's a good point. At the end of the day...
Yeah,
okay, I'm sorry.
That was my point to the physician I wanted to follow up on. When we say acceptable experience, to me, that shouldn't be, if we're writing law, ambiguous. So is that a determination that is actually made by a board, or is that the determination made by the physician inside the practice?
That would be the board.
Okay, Representative Watkins.
The board, certainly, as it says there, in accordance with board criteria, but the physician is not going to give that PA or nurse practitioner in their protocol unless they feel that way also. So there's dual.
Dual, okay. And
Representative Brown, can I follow
Please.
on this? If you finish the sentence, as determined in accordance with board criteria, I was going to mention that's why I say the board. And again, ultimately, remember, if there's something that's going to go wrong here, and the physician's got the protocol with the, he too is on the hook as respects liability.
Well, and that's actually
So
right.
I get he's going to be, if there's a legal action, he's going to be named just like the rest of the world.
Right. As you're aware, there's been a lot of discussions lately about boards and more to come in the future.
Yes.
And exactly how much power are you going to give away to them as a lawmaker?
Well, I will tell you right now, I think the medical boards right now, the standards are set by the boards. I mean, that's
Right.
existing law. So, with all due respect, I'm not going to change that.
Right. Finally, if I may, one last question. Anytime I see this kind of stuff, usually someone comes up with an example of whether it's access or shortage, or why is this needed? Why do we, if the concern is that maybe we're having too much imaging going on, what's the argument of why what we're currently doing isn't working?
I have been told.
Is there underserved areas?
Yeah, I've been told, and you hear that word like you just said, underserved areas, access. I've seen this. I've seen some maps on some of the areas of the medical field, I guess, in the state. And I'll give you an example, just if I can use not the APRNs, but another example. Whether it was psychologists, whether it was social workers, whether it was counselors, marriage and family therapists, we've got certain places we might have just one of those practices represented. So it is, particularly when you get outside the metro area, it is a problem sometimes, and access with people that can perform this function. And that's why the protocols are established with these folks. Can I give you a specific example? No, I cannot.
Okay, so, and I'm just trying to get to the logistics. So if we go to that underserved area, it is the intent, Dr. Watson and Senator Miller, it's the intent that if a physician isn't in the office that day, he or the board, if they have enough experience, can then grant an advanced practice nurse the right to order imaging if they happen to be working in another office that particular day.
After 5 years of experience.
After the acceptable.
5 years.
That's what your protocol does.
That's the reason why we need this, is the example we just talked about.
That's a fair example, yes.
Okay, thank you. That's it. Thank you.
Okay. Representative Pack.
Thank you, Madam Chair. To follow up on Representative Reinder's question, on line 30, if we are going to give the discretion to the board to determine acceptable experience, why are we limiting it to 5 or more years? Imagine a situation, an advanced practice nurse who's do this stuff all the time, I mean more advanced, no pun intended, than the other peers. It seems to me we're going to give discretion for the board to set rules and determine what is acceptable, that we shouldn't statutorily limit how many or dictate how many years minimum they should have.
Representative Watt, do you want to answer that one? You want me to?
Go ahead, Representative Watson.
I mean, Representative Pack, I mean, certainly it is always arbitrary whether you pick 2 years, 5 years, or 7 years. That was, and it felt to be, from experience, that was felt to be the number that was arrived at. And I mean, I don't have any magic number there. I mean, why is a internal medicine residency 3 years? Why is a neurosurgery residency 5 years? 7 years. So I mean, it's going to vary. And from my experience, that was what I felt comfortable with. And in testimony, we'll hear that. I'm sure there are some that at 3 years or 4 years would probably be okay with that, and there are probably some at 7 or 8 years that the physician will not give them the they'll not delegate that. There's certain in certain situations where you may feel pressed to order MR scans in situations where it's not necessarily indicated. then in consultation with the physician, which should always be an option. And if there is somebody that is not, that is off that day, there will be someone that should be delegated as the supervising physician. So access is certainly an issue, but it is also, communication should always be available.
And one other thing, too, I think in the metro area, I can't tell you how many times that I've gone to see the doctor. I don't ever see the doctor. I see the physician assistant, or I see the APRN in many, very cases, particularly in the metro area, because the doctor could be out doing surgery or doing something someplace else, too. So there is an access to a degree also in the metro area, I think, just because of the fact that, particularly if you get into certain professions.
Are you comfortable with 4 or 3? I just don't see the need for that. If you're going to delegate it to the board, and
I guess
my guess is they're going to say you're going to have at least 4 or 5.
The reason I deferred to Representative Watson, his medical experience is a lot more than Fran Miller's. He came up with 5. If the committee, or based on testimony, you want to make it 4 or 3, I have no problem with that. If you want to make it consistent between the two practices, I would recommend that. But if it's 4 years or 3 years, I don't have any problem with that. And again, you may want to hear some testimony before you would make an amendment and such, but I trusted his judgment when he used the number 5.
May I follow up with a different
Sure.
question? On line 37 to 40, this bans a delegation by a physician to an advanced practice registered nurse, no matter how many years experience, based on location.
Right.
Do we need a life-threatening exception that exists in the first 2?
I mean, certainly in a Minute Clinic in CVS or Walgreens and so forth. I mean, that's life-threatening situation in the drugstore or supermarket. You go to the emergency room.
So if it's not going to happen in that situation, I guess, then why do we even have the provision in there?
No, it doesn't.
Yeah. I mean, why not just ban it? I mean, I don't understand why we have that provision.
I'm sorry, I don't follow that.
Would you restate that for him?
That's what it's saying. It does ban the nurses working in those areas and PAs working in that area from doing them at all.
You can't do it in those circumstances, is what he said in this portion. It says.
Do you have these kind of machinery in Kroger's, Walgreens?
Well, no. Well, most physicians' offices don't have the MR scans or CT scans in their offices. They're going to order it. You order it, and it would be done elsewhere.
It's not like your blood pressure machines and this other kind of stuff you see in CVS and folks.
It could be.
Okay. Thank you.
Okay. Representative Broadwell.
Thank you, Madam Chair. One other question is along this same line of the acceptable experience, Senator. Was there any discussion about additional training or certification for both of these practices in order to be granted this privilege of protocol? Was there any discussion in preparing of the bill of additional training for this privilege?
There wasn't. In fact, prior to the substitute, it's my understanding that Georgia was the only state in the nation which had a restriction on what an APRN could do. That was prior to the original hearing in the Senate. So we're the only one that just limited to life-threatening situations. Since we passed the bill in the Senate, I've had conversations, like I said, with the pediatric folks, several of them. The radiologist in the testimony brought up the fact that about too many tests. And so from a standpoint, there never was anything put forward that in order to do this you needed more training. So to my knowledge, I didn't discuss that with the board, but no one's brought that point forward at all.
And of course, certainly the board could promulgate rules and regulations.
That's correct.
As far as what certifies training.
That's correct.
For both of these practices. Great. Thank you very much.
Sure.
Representative Peake.
Thank you, Mr. Chairman. Senator Moore, Good to see you again. With great appreciation for what the nurse practitioners and PAs do in our state, which was great work. I guess my fear and hesitation on something like this is that we continue down a potential slippery slope of taking the physician out of the equation of that patient relationship, and that I have some concern of that. I'd love to, hear perspective of the only physician on this panel regarding that, but I'd love to hear your perspective as well of that, because I think that's a potential danger that we get into these major medical procedures where we don't have the physician involved.
I understand your concern personally as well as professionally, what you're saying, and I'll let Representative Watson comment, but understand neither one of these two positions, APRNs or physician assistant, cannot do this without a protocol from a physician. Somebody has signed off on this to do this. So they're not just going in and seeing APRN and he's making that determination. It's got to be according to the terms and conditions in that protocol, whether it's a PA or an APRN. Now, if the physician feels comfortable enough doing that, then so be it. And that's maybe the world that we are in today, particularly as you have less and less general practitioners, where we've got a real issue from a standpoint of accessibility. Everybody wants to be a specialist now. We talk about this shortage that, I forget how many doctors, Ben, you can probably comment on this, but the potential shortage of what you and I would call general practitioners, which are now called internal medicine doctors, but it's pretty severe over the next few years. So, again, anything that's being done here has been signed off on by a physician. And that's, I think, a very important distinction. He might want to comment on as well.
I guess my only comment, I just, with all due respect, I just have some concern about heading down that path. But,
I understand.
Yeah, I mean, it is, and I agree with you, Representative Peake. I have mixed emotions about it. A lot of my orthopedic friends, are concerned. They many times with they feel the pressure, or insurance companies require, sometimes indicated, sometimes not indicated, about doing MR scans related to knees when the exam is just as good, if not better, and they'll know that they need an arthroscopy. So the PAs and the physicians get the pressure to do MR scans. So from their perspective, they think that it is unfathomable for anybody to order an MR scan of a particular shoulder or knee without bouncing it off or discussing it with the physician. Certainly that is the case. Now, on the flip side of that, a PA who's been in a physician's, orthopedic surgeon's office and has examined, knees and hips and shoulders and has the experience there, then that certainly leads to a lot of credibility from that standpoint. So that's what the protocol would be based on from that perspective. I agree with you. I mean, I still have mixed emotions. I will tell you, friends of mine will not be happy if this passes, but that certainly is the case. Representative Dexter Sharper.
Thank you, Chair. When I look at this, and first of all, we got to understand that the PAs and the nurse practitioners that we're talking about, they are considered professionals at what they do, and they have to, a lot of times go off protocols and also the experience from the physicians. So my concern is that I don't want to limit them in what they're doing. And I think, for one, I know we have testimonies, but we need to look at this substitute more in detail. I don't think there's enough information of what we're seeing here, the way it is, that could be really supported by me, because in sections, in section 1, and when you're looking at item number 1, which is on line 28, and then you go to line number 3 here, line 37 in little section 3, that's very contradictory among itself about who's able to do it, because now you're looking at individuals, not so much, you're limited to location. But if you have a person that's working in that particular location who has the experience, then it's contradictory to me. Secondly, if you have a physician assistant who's maybe worked as maybe an RN, or a nurse practitioner who's worked as an RN for a lot of years and have the experience of seeing these patients, then go to school, they probably be better off than a person that's over 5 years and they've been maybe doing it 2 or 3 years. So therefore, I think we need to look at this whole thing a little bit more. Maybe some of this can be, in the testimonies, but I think we're limiting instead of allowing them to do what they need to do, because I don't think personally that a lot of them are just doing it to be doing it, and I just want to hear, I guess, more testimony.
You've got a valid issue there. Keep in mind the original bill did not do this. This has been come up with as a compromise to try to please a whole bunch of different parties. So I understand what you're saying, and again, this was the alternative that was developed to try to keep everybody comfortable.
Right.
Where and where probably means that not everybody's happy, or everybody's not happy, I'm sure. So the rationale was to try to put a mix in here to have the best of all worlds. Is it perfect? No, I can't say it's perfect, whether it's 5 years, 4 years, 3 years, but that was the rationale behind it.
Okay,
and that's right. And I appreciate all the work that Representative Watson did to try to make that happen.
And can I follow up there, Chairman? Because, when we look at this, it's no longer about the professionals on each side who's trying to do it. The number one concern is that patient. And if the physicians, physician assistants, and the nurse practitioners sitting here dealing with a patient, I don't think they should have in their mind that, oh man, I want to order it, but I don't think I should. Because I got pressure on me that is one more sense of radiation going on this patient when we're looking to find out what's actually wrong with this patient. So I think we don't need to move too quick on something like that just to satisfy one side or the other, because it's all about these patients. You know what I mean?
If it helps you a little bit, I've got a letter here from Children's Health Care completely in support of the original bill. I've got testimony from Emory Medical, Emory Nursing, numerous people from the standpoint, and they talked, again, some of the things they talked about is the critical shortage of primary care physicians, that more APRNs are needed. They hold master's or doctoral degrees. Again, what Representative Watson has tried to do in the substitute is a compromise to acceptable to all parties. But from a standpoint of someone professional about what to do, I don't think the situation you just gave, I'm worried about doing one more test, I don't think that's going to be what comes into play. I don't think that's going to be affected by this particular bill. But that's just my opinion.
Okay.
Yes, sir.
Thank you.
Thank you for your question.
And Representative Sharper, to your people working in the clinics and all, that is really beyond what they're supposed to be doing in the mini clinics, so that's why that would not be applicable.
Okay, good.
Okay. So, and if a nurse practitioner decided to move to another job and work under another physician, then if she'd had the experience and so forth, she could be granted that right if she met the other terms. But people that need scans and things like that, it's sort of outside the scope of what should be going on there. Okay. Representative Pruitt.
Thank you, Madam Chair. And I'm just curious if there's anybody here with the Rural Hospital Association that's going to speak on the bill. And this question may be more for them if they're going to. I can hold on.
In fact, let me see here. In fact, we had the original bill now. I can't comment on the substitute, okay? But the original bill, let's see, we had Ethan James from Georgia Hospital Association spoke in favor. Tim Kibler from Georgia Alliance Community Hospital spoke in favor. Emory, I mentioned. Hometown Health spoke in favor. Georgia Nursing, so on and so forth. So at the original bill, the Georgia Alliance of Community Hospitals spoke in favor of the original bill. So I don't know, is Tim here? I'm not sure. So there he is, okay. He signed up to speak, so he'll
Then I'll hold my questions, Madam Chair. Thank you.
Representative Kidd.
Quick comments. Maybe I can help my friend, Mr. Millar, who used to be in the House also. Maybe he'll help me in rules tomorrow.
I couldn't hear that number. No, I'm sorry.
Protocol, we've heard the word protocols thrown around here. To my belief, there is no such thing as a cookie cutter protocol. Every protocol that a physician has with their nurse or their PA is a separate directive approved by the Board of Medical Examiners for that physician and that particular nurse or PA. no two are necessarily exactly alike. Is that not correct?
Mr. Watson, is that correct? I can't tell because I'm not dealing with protocol business.
I think that's correct.
Could you repeat that? You say individual.
What I was talking about is that there is no cookie cutter protocol, that the Board of Medical Examiners approves a physician's protocol for his or their personal nurse or their personal PA. And there's no quote-unquote cookie cutter protocol. So every protocol is different depending on the education criteria and what the physician wants their PA or their nurse to do. Here again, approved by the Board of Medical Examiners.
I would say.
Right, and I'm sure that others will be able to testify for this. I mean, there certainly should be some cookie cutter aspect of it, but will there be certainly carve-outs related to that particular PA or nurse practitioner in that particular physician's practice and so forth, expansion and contraction and so forth?
If I refer you to existing law on Section 1, it talks about which acts may include, without being limited to, the order of drugs, medical advices, medical treatments, diagnostic studies, or radiographic imaging tests, is how So yes, it could be some, all, or none of the above.
I was trying to allude what we use the word protocol, that it's individual protocol for the individual physician.
It's tailored.
And their PA and their...
It would be tailored, that's correct.
Representative Kidd, the legislature sets the parameters in what we will let them do. And then that's the guideline that the Board of Medicine, and I will tell you that this issue was discussed at great length when we passed and expanded the Nurse Practitioner Act several years ago. And it was very specifically put in there that they only order them, and not order CT scans, and the other more extensive tests where you are exposed to more exposure. And that came through Judiciary Non-Civil, which at the time Speaker Ralston was the chairman of that thing. And it was discussed, and it's not an accident that that was in there, keeping the nurse practitioners in concern for cost, for exposure to patients, even at that time. And there is a lot of new data out showing, and I think it's what Dr. Watson's so concerned about how in the last 10 years, how much more radiation we get than we did 10 years before, and there are actually some cancers that are caused by over-radiation. It's that kind of things that we are finding out that is making us look at that and maybe tightening it up a bit.
Yeah, because you're talking not just CTs and MRIs, but you got nuclear imaging, you got digital mammography. I mean, so it's a continuing expanding field too as well.
Right. Okay, Representative Harden.
Thank you, Madam Chair. I'd like to follow up on something Pat was asking, and it appears to me that we are taking a fully licensed and a physician who is licensed to practice in the state of Georgia, and an APRN or a physician assistant who also is fully licensed to practice in the state of Georgia with 5 years of experience. And we're saying, depending on the practice site that you choose, we're going to discriminate against you and your professional ability. And I tell you why this comes, and I don't know what a retail clinic or a retail store, I'm not sure where the definitions are on that, but I have worked in a small town, Warwick, and there's one in Araby, little clinics that the hospital has actually set up, and they are run by APRN with a protocol with a physician. One of them's in a bank building. Would that be not allowed? Are those people not qualified? And they give access to a lot of patients who otherwise would not have access. So do we want to put into law a discriminatory clause against a professional simply because of where they choose to practice?
You're asking me?
Well, yes, sir.
I'm telling you this. If you want to amend the number of years, or no years, or take out Section 3 of 37 to 40, that's going to be up to the wisdom of the committee. That is not the original bill that I came to you with. Okay?
Representative Harden?
So,
Yes, ma'am. Yes, Chairman.
If you want to clarify that if they're hospital-based, and that would be an option also, I think that the reason, perhaps as this was discussed, and Representative Watson can do that, many of the pharmacists and supermarkets and so forth have protocols done by a physician that doesn't even practice in your area and is not there to supervise their work or take care of the patients that, might the follow-up and so forth of that, and I think that is why that was put in. It was not meant for hospitals or...
The only thing I'm saying is it sounds discriminatory,
Yeah,
regardless of whether it's, whatever the situation is, and if we put in there they had to be hospital-based, then that's going to mean all of them got to be hospital-based. In my narrow thinking, I guess, we should treat all professionals equally, is what I'm trying to say.
Yes and no. What I was trying to get at was minute clinics, and that's what I worked with legal counsel.
All right, did they actually define, of course, I guess all clinics are probably retail. I don't know of a wholesale medical clinic, but I guess maybe I'm looking for a definition of retail clinic and why some retail clinics would not be acceptable when you got the same professional training in those clinics.
Representative, am I correct that if I'm with a large national drug chain and I could have a protocol established by a doctor out of Chicago
Yes.
with an APRN in Hayhira, Georgia, is this what we're trying to get to eliminate this type of thing where it's not the community type thing that I'm just trying to think of it.
The minute clinics that operate, that's not the purpose.
But is that an example of something that?
Yes.
I see the chairman's nodding her head. I think if that's what you're trying to discourage, where it's not we're not talking hometown doctor here is what we're talking about. Is that what you're trying to do here?
All right, then could we cut out the local pharmacy and local physician that are working together to have this kind of clinic in a local pharmacy with a local physician and local advanced practice nurse or PA?
Representative Harden, do you really think you want to be dealing in your clinic with somebody that's going to need a CT scan or an MRI?
I'm not.
What?
All I'm looking at is the discrimination involved here, and I've got a problem with us telling one professional they can do something, but another professional with the same or better training they can't do something because of where they decide to do it. That's my only problem.
That exception would be. Okay. Understand your position. Representative Watkins, and see if he can work on some language. Representative Fullerton.
I spoke with an internist in Albany over the weekend about this, and we face a great shortage of primary care physicians in southwest Georgia, and nurses or other people of this quality of training and licensing are really very important. What Representative Harden is saying is that we face a whole different experience in medicine than the metro area, or really even North Georgia. And it's very hard, and it's going to be harder in the near future not to have people like this available to take care of some of the load that we have. We also have a lot of high blood pressure, a lot of obesity, diabetes, and things like that, much higher than the rest of the state. So it's something that somehow we have to deal with. And, perhaps Representative Watson can comment on that. We need to use all the opportunities that are out there.
I don't know where you've been, but when Representative Kidd comes to the Rules Committee, you come too. But you really, what you've done here is that was the reason for the original bill. the major portion of it is the fact, what you very well stated right there, the fact that we have different needs in this state, and we have shortages in certain areas, and yet, even though I didn't have it in the original bill, I understand the concern, particularly with young people, particularly after my conversations after the fact with the pediatric doctors. So there's a compromise here somewhere, okay? But you've hit the nub of why the bill was drafted, and when it came to Chairman Hunter and myself, okay? So I think there's a grounds here for both things. So I appreciate your comments very much.
And Representative Fulton, let me just make it clear, this does not interfere in any way with nurse practitioners working with diabetes, high blood pressure, and we are talking about a very specific part of their practice. And that has to deal with ordering things like MRIs and CT scans. Representative Pack. Okay, thank you. Representative Henson. Okay. Representative Reiners.
Thank you, Madam Chair. I concur with Representative Harden. People up here have a tendency to use the extremes as their poster child to make their case, and we have to look at who could potentially game the system. When you talk about a physician running a retail clinic from Chicago, Senator Millar, there's got to be language that addresses that, but I don't see it. What I do see in Southwest Georgia and South Georgia is a care group that goes into Dawson on Tuesday and Warwick on Thursday. All right, and that's if we talk about access, and that's what you said, this particular language that, in my humble opinion, excludes the opportunity for access is a contradiction to the purpose that you said we needed it to begin with.
Can I answer that?
Does that logically make sense to you?
Representative Reiner, this is not my language.
Well,
okay,
whosever
let's
language
get
is
that
this?
perfectly clear. I think I've tried to say that.
Over.
That it's a compromise of some people have come up with to try to make this work. So this is not my language. This was not the bill that was brought, and that's where we are. Now, if we need to change the language, because he raises a very good point, that's fine. We'll do that. But let's get that perfectly straight.
When
this
I started, I asked,
language.
what's the case of why we even need this? I know why, because we've been asking about this for years, and
Right.
we're trying to split this baby. Me and you know that.
Right.
This isn't our first rodeo. That's exactly what we're trying to do. But if we're trying to sit there and tell somebody that wants to open up in a bank in Warwick, Georgia, for someone that can come see a doctor once a week, and that doctor thinks that's the right thing to do, and their practice is 40 miles away, you know what I tell them? I trust you. Order it.
Yeah, thank you, Chairman Reinders. That is not aimed at Southwest Georgia. It is not aimed. It is aimed at minute clinics that have no intention, and for all practical purposes, that's the language that was come up with. Receptive certainly to open up further language. It does not keep anyone from practicing in a bank store or a pharmacy or anyone. It does not keep them. The only thing it would keep them from doing, if you interpret it as such, and that's not the way that Betsy had drawn it, that was not the intent of that. And we can certainly alter that language. I strongly concur with you. And remember, we're not talking about practicing. We're talking about ordering CT scans, MR scans, PET scans, nuclear scans, of which you don't want a lot of.
We know what the bill does. Yeah. I'm just saying that this language here says using terms like out of Chicago. Now, I mean, that's the example that was used.
Okay. And if the committee will allow me to make this clear for you, the bill allows for the nurse practitioner to order these if there's a clinic working in a bank or in Representative Harden's pharmacy locally, and a patient comes in and it looks like there's a life-threatening situation and they need to be taken to the emergency room right away and have a CT scan ordered right then. The nurse practitioner can do that. They work under a protocol with a physician, and all they have to do, if they have patients that come in that think they need a CT scan or an MRI, then they call the physician that is their collaborating physician and say, I think this needs to be ordered, and the physician can then talk to the nurse practitioner or PA asking about the patient, and together, in a collaborative way, they can make the decision, and an order can be given by the physician. Most of the time, in places like South Georgia and all, it will take you 2 or 3 days to get a non-emergency MRI or CT scan ordered and taken place. So they don't lose their ability to do that. It's just that if it's not an emergency situation, they collaborate with a physician in this process of trying to not order so many tests and to work together. So they don't lose that ability.
I'm just not trying to exclude.
Just made that clear. I'm just trying to make it clear. Representative Chokas.
Thank you, Madam Chair. And Senator Millar,
read it.
I'm in a very, very rural part of the state. And as a matter of fact, in my adjacent district, they've announced the closing of a hospital in Richland, Georgia, that will take place this Friday. Access to health care is a huge issue for us because the miles we have to drive to get to a physician is great. And with that being said, what I want to point out is that one county in my district, Sly County, doesn't even have a doctor. The only medical attention that you can have is through a nurse practitioner. And so that's, for that particular county, that's their medical home, unfortunately. I find that tragic that we can't offer that. And I was wondering if you could tell me how your bill will help my district.
Well, I can tell you how the original bill would help you, simply because the fact it doesn't have any restrictions upon what these people can do. Okay? Now, again, though, I go back to the fact there are concerns expressed by the radiologists, expressed by others, about maybe we're doing too many of these tests overall, so on and so forth, particularly with young people. I think that's what Dr. Watson tried to put in here as a compromise. If access overrides those concerns, then we go to the original bill. If these new concerns also are important to people, then we take what's here, the substitute, if you will, and refine it. So, you pick your poison, I guess, for lack of a better word. I mean, where you come from, where you think, if you're from certain areas where that's the most important thing, then you probably like the original bill with no restrictions. Okay? For the other people that are concerned about overexposure to radiation, so on and so forth, and maybe we shouldn't be doing this with kids, or these retail medical clinics that try to cover, then you put some restrictions in. Again, I will tell you this. I think after hearing this conversation today, Madam Chairman, to be fair to your committee, particularly on day 36, whatever it is at this point, maybe 38 by as long as I've been sitting here, I would suggest to you that you set up, that you possibly have a subcommittee here set up and over the off session work on this thing and come up with what's acceptable to your committee as a whole. I mean, it took me 6 times to get this out of the Senate, in case you all didn't know that. Maybe some of you did.
Turn this down and vote this bill down, and then didn't they vote?
Then we had a religious experience, and thanks to Lieutenant Governor, and we did pass it. We didn't need 120th vote, but we did need 29 votes to pass it. But I would suggest, because I think there's some valid concerns here, and if we're going to do this, folks, if we're going to do it, let's do it right. So, look, I was brought this bill. This is not a pride of ownership thing, but I do think we've identified that there's some real problems in this state on access, and there's concerns, again, going back to the situation, particularly with the younger people. At my age, a little more radiation probably helped me. Okay, that's a little bourbon, right, Mickey? But anyway, so I would suggest that you may want to deal with this and put it in a committee, and I'd have somebody knowledgeable like Representative Watson. I'll be very happy to sit in when you want me to, And if you work on this in the off session, maybe bring back a bill for next year, God willing, we're all here, and go forward from there.
So
That's just a thought for you. And all these people won't have to testify. They can save their time and testify another day. But if they so choose.
Representative Hawkins, are you messing with your light?
Table this bill.
Well, let him finish.
And have.
I was worried about day 38.
And with the chairman's consideration of forming a subcommittee to study this matter further.
Okay, we have a move to table, and we have a second. Is there other discussion on the bill? No discussion? Okay, I'm sorry. Representative Rogers.
Why not listen to some of the folks that have come to speak for or against the bill?
Well,
Since they're here.
I think that's probably a real good idea. I don't think we need to listen to everybody that signed up. We'll be here forever. Let me take...
I mean, they're here on their time. It'd be good to hear from them, so they do have the option to waive if they want to. I think Senator would appreciate that, probably.
Pardon?
Why don't we hear from the people?
Okay.
It's like cocktails for 45 minutes. Maybe. It's not cocktails for 45 minutes. I forget you guys are
okay, guys.
Let's listen to the people that are here. Then you can decide on the table, Madam Chair.
Huh? You want to? All right. I am going to go ahead and just call the question. I'm going to... I know people have traveled. You're hearing the discussion I'm getting on the committee. I really, since people have traveled here, I hate to cut it off, but I'm going to let my committee decide. We have a motion and a second. Is there any other discussion? Anybody else that feels strongly about this? We have a motion and a second to lay this on the table and obviously not have people testify to it. So everyone in favor of the motion, hold your hand up.
I know, but I thought they testified. I just walked in and listened to this. I mean, really, I'm sorry I've been in another committee. Y'all been here an hour?
We've got it out. And everyone...
I can't wait to vote on your bill.
Everyone opposed, the same. So I would be the... Okay, I think the ayes have it. I do apologize if people have stayed here and
Ask
waited.
a question, man.
Yes.
If you are going to set up a subcommittee on this, and I think the interested parties could then come and testify at that point, obviously, if you're going to be...
Senator Miller, you are in the Senate now, and you will run your committee, and
I just want to know, I'm just asking if you were.
I will think about how I want to set my subcommittees up, and I'm certainly going to be fair about it, Senator, and let everybody have a discussion. But, we may do things a little differently over in the House, and when you set up a subcommittee,
I learned from you for 12 years, man.
That's right. Thank you very much. I should have known after all you talked for those 12 years you were going to have a suggestion for me. Okay. Thank you very much for coming and presenting this. So, that's...
Where's the lawyer?
Can you say it?
Yeah, we actually
Senator?
We actually vet the bills over here.
No, you read them.
Yeah. So anyway, thank you very much. Okay, hold on a second.
You done?
Yes, I did get the letter.
Let me get this back.
Okay.
You know which one.
I don't know which that.
This right here.
Okay, I don't know. Okay. All right. Excuse me, we are not dismissed. Sorry, Carol. Can you take that? Okay. All right. Thank you very much to the committee. We will go now to House. Okay. House Bill 363. House Bill 363, and that is supposed to be me. I love the fact that I got my name on it. This is this is a bill about lactation specialists, and I would ask the person that is most knowledgeable about this issue to come up, and she can present this proposition to you. This bill is going to GORC. That is the committee that decides whether, we can add another licensed group, and it will be going there this summer. But they asked that they could start the process and the discussion with you. So we will not elongate that, but if you will identify yourself, and I will let you have the floor for a few minutes.
Madam Chair, my name is Leah Aldridge, and I'm on the board of Healthy Mothers, Healthy Babies Coalition of Georgia. I'm also a member of the profession seeking licensure. I'm an internationally board-certified lactation consultant. We help women successfully breastfeed. My testimony today will focus on the importance of breastfeeding to Georgia's women and children, and highlight how licensure of internationally board-certified lactation consultants will improve access to breastfeeding support, will protect public health, and will allow our mothers to identify competent healthcare providers. You're going to hear from the AAP after me about the benefits of breastfeeding. But what is important to remember is that the incredible contributions to health that breastfeeding affords has a direct impact on infant mortality. Something that Dr. Brenda Fitzgerald has been talking around the state about reducing in the state of Georgia. Georgia is in the top 20% nationally for infant mortality, and we're in the bottom 20% for 6-month breastfeeding rates. There's a direct correlation there in the research. If women could follow the AAP, the American Academy of Pediatrics, recommendations for breastfeeding, over 911 babies would be saved each year. Breastfeeding also saves significant healthcare dollars for our state, dollars we desperately need. Researchers at Harvard have estimated that, again, if women in our state and in our country could follow the American Academy of Pediatrics guidelines, we would save over $13 billion a year. The federal government spends $864 million of our tax dollars on formula each year. And our own state WIC office estimates that for every month a baby is exclusively breastfed, WIC and our state Medicaid offices will save $160 per baby per month for the first 6 months alone. We should be hunting down those savings in Georgia. Let's talk about how many women are breastfeeding in Georgia. 70% initiate breastfeeding. In Macon, it's 32%. They have one IBCLC, that's the lactation consultants, in 2 hospitals that are birthing in Macon. In Albany, we're up to 50% initiation rate. Phoebe Putney has 2.5 full-time equivalents in their birthing hospital there in Albany. At Northside Hospital, we have 90 to 95% initiation rates, 18,000 babies across 3 campuses. They have a fully staffed lactation program at Northside Hospital. Overall, it's 70% women starting, which is good. They hear the benefits of breastfeeding and they know the savings associated. By the time they hit 6 months, we're down to 13% of our women breastfeeding. They quit before they can reap the health benefits or the financial benefits. So what do we do about it? We need to provide, the research has established, and I've got copies of the research for each of you, that the assistance of the IBCLC helps women start breastfeeding, continue breastfeeding, and exclusively breastfeed. We need to hook our Georgia women up with IBCLCs in our state. How do we do this? Through licensure. Licensure will, number 1, establish IBCLCs as part of the healthcare system. providing assurance to our physicians that the people to whom they refer are competent. Number 2, it will assure the public that the person that's coming into their homes is competent and has met a criminal background check. Number 3, it will eliminate current confusion. Right now, there's La Leche League volunteers, there's CLCs, there's IBCLCs, there's CLEs, there's doulas. Nobody has any idea what anyone's training or credentials are, or where to seek out competent and qualified help. And number 4, licensure is going to impact the growth of the profession. For these reasons, Healthy Mothers, Healthy Babies is supporting licensure of lactation consultants for the state of Georgia. And I want to close my testimony by sharing with you the work that we do. I pulled from my notes the story of a woman I saw in Milton, Georgia, July 20th, 2012. She had her first baby. It was a baby girl, and I arrived at her home when the baby was 10 days old. These were 2 Georgia Tech grads with health insurance that had the wherewithal to hire me. As I arrived, they told me that their baby was stooling, had only stooled once in the last 50 hours. As a point of reference, babies need to eat to stool, and they need to have 3 to 4 stools every 24 hours. This baby was not getting enough food. The mom had seen the pediatrician, had been discharged from the hospital at day 2, had seen the pediatrician at day 3, all according to normal protocol. She was educated. We were at day 10 and it was a Friday. She wasn't expecting to see her pediatrician until 1 month, according to AAP guidelines. She wasn't going to see her OBGYN until 6 weeks. We're at day 10. I weighed the baby below birth weight, another red flag. After breastfeeding, the baby was willing to breastfeed with assistance. After 45 minutes, the baby transferred 1 ounce of milk from the mother. She needs about double that every 10 to 12 times in a 24-hour period. I asked the mom if she had any pumped milk. No. Do you have any formula? No. So I sent the dad out for formula. Because what we had to do was we had to get this baby some calories while we solved the milk supply issue. It turns out, after talking with the mom, she had some significant history that was impacting her supply. She had polycystic ovarian syndrome. She had low thyroid. She had been treated and been watched for some issues with her white blood cell count. They were watching her for leukemia. She was a healthy woman with a healthy baby, and it's the IBCLC that puts the two together to see if breastfeeding can work. It wasn't working. So I taught the mom how to feed the baby with formula at the breast with a tube, and taught her how to increase her supply. And a lot of people might say, hey, that's great. You know, she used formula. I was fed formula. I'm fine. Lots of people are fine. My children are fine. But what's important to realize is that if she had made a different decision that day, if she hadn't had the courage to invite me into her home or the resources to pay me, she would have doubled her child's risk of ear infection that year, quadrupled her child's risk of RSV that year, tripled her child's risk of GI infections, increased her child's risk of getting asthma by 70%, increased her overall risk of dying before her first baby by 30%, and doubled her risk of dying of SIDS. So I'd like to close not with my words, but the words of, we have a petition. There's a lot of excitement about this bill. And 524 Georgians have signed our petition and have left public comments. This is a comment left by an RN practicing in our state. In Georgia, estheticians, people who give facials, have to be licensed. Cosmetologists, nail techs, vet techs, barbers, librarians, hygienists, hearing aid dispensers, athletic trainers, dietitians, embalmers. They all have to be licensed in Georgia. Certainly if someone has to be licensed to touch my face, my toes, or my dead body, shouldn't we also want people who are touching breasts and babies to be licensed? As it is, her words, not mine, As it is, my dog has more protection right now than our babies have, and Georgia needs to change that. Thank you for your time, Madam Chairwoman.
Got a question? Go ahead, Representative. You got it on.
Thank you, Madam Chair. You know, this licensing thing is just out of control in Georgia. I mean, and I'm not trying to say that the profession isn't honorable, because it is. But, you know, the examples that you gave, you're talking about people that are using chemicals and, you know, lethal chemicals, some of them, and chemicals that can give someone a third-degree burn. And, I mean, so that's kind of a stretch to compare the reasons that licensure should be for this profession. So, I mean, I got to hear a little bit more, because with licensure there's going to be a fee, and there's going to probably be some other extensive exams, and, you know, why is this totally necessary? I don't think I heard that in your testimony.
There are others who are here to testify, but responding directly to you, the real issues that we face every day are about babies actually surviving. So I've got a woman, another IBCLC, if you have a few minutes, she'll share her time with someone who is not credentialed as an IBCLC. There are so many people out there calling themselves lactation consultants who don't have the education or clinical experience that the IBCLC does. Mm-hmm. And she's going to testify today about the risk of harm to the public in uncredentialed lactation consultants.
Okay, but now in the example that you gave us, the baby wasn't gaining weight. And any mother knows if my baby's not gaining weight, I need to find out why. And so I'll just give it some formula, or drop a cereal in the milk, something to help that baby to gain weight. So I'm just trying to understand why is a license necessary?
Madam Chair, if I could just try and answer this. And
Identify yourself.
I'm Mary Frances Williams. I'm working with Healthy Mothers, Healthy Babies. I think this might answer your question, but obviously we've got a way to go, and we're going to go through the GORC process. But lactation support has been identified as is one of the essential health benefits that's been established as part of the Affordable Care Act. But so right now, the only folks who are getting this are pretty much folks who can pay for it. If and hospitals cannot, they cannot get reimbursed for this. Doctors' offices cannot get reimbursed for these services until there's some sort of licensure procedure. So at some point, we would like for women of all income levels to be eligible for this kind of service. And, you know, it's just that you will not have any reimbursement without licensure as a healthcare provider. And that's kind of one of the reasons.
And that's the answer. Thank you.
Okay. Thank you, Representative Randall. Leah, do you want that person who's going to talk about some of the problems to come up? Okay. Representative Henson? Sorry.
I just had a question as you talked about this, and one of the concerns that I have is for mothers that aren't breastfeeding because of time factor, cannot breastfeed, choose not to breastfeed. I want to be sure that we're not making them feel guilty for not breastfeeding, but for giving formula instead. Because you brought up the fact of the savings with formula and everything else. Because you're sort of implying that every mother can breastfeed, and
that's not always the case. That's correct.
I know. Mm-hmm. So, I mean, somewhere in there I want some assurance that we're not going to make someone feel guilty that they didn't breastfeed until the baby was 1 year old. Or if they're hourly workers with multiple children, oftentimes it becomes too difficult in the formula. You know, if someone is a single mom, is, you know, I hate to say it, but sometimes you just have to put what's easiest and out there.
I think that your comments are ones that we face all the time in this, working in this area of healthcare. The bill is about just ensuring that those who want to seek out the care of someone to help them breastfeed knows that the person they're seeking out is competent and has training and experience and has a license, so that if I'm going to pay you for your care, I know what I'm getting. It's about consumer protection as well. Certainly there would be no pressure on anyone to seek out the care of an IBCLC associated
Can I just
with
ask
this
one
bill.
other question? When you go see someone, about how long are you interacting with the mother, with a lactation specialist?
So this brings up a very important point. Other licensed healthcare professionals don't have time to do the work that we often do with mothers. A lactation consult can take up to an hour to an hour and a half.
I understand that, the hour,
Okay.
the hour and a half. I'm asking, like, how many times, how many days, how many times are you meeting with the mother or whatnot? That's my question.
Usually it's dependent on their financial resources. In my practice, I'm in private practice here in Atlanta, I generally see mothers once. A follow-up, sometimes there's follow-up phone and email support that we provide, but an in-person consult generally is once. Sometimes there's a short-term in-person follow-up, that would be twice.
Okay, that's what I was wondering. Thank you very much.
Representative Mitchell? Okay, hit it by mistake. Representative Morgan?
Thank you, Madam Chair. I like how some of our male colleagues are allowing the women to go first. Thank you, Representative Pack. So, to Michelle's point, to Representative Henson's point, I think you actually raised a great point. Everyone knows that I have a daughter, and I will tell you that in my experience, I wouldn't say that I was made to feel bad, but there's a lot of emphasis put on breastfeeding. And I will also tell you that when it did not work for me, and I did see a lactation consultant in the hospital and even went after I had my daughter, I felt a sense of failure because it is, when you go through the Lamaze classes and everything else that you take, everybody is talking about breastfeeding. So you kind of feel like you have to do it. So that is an issue. I don't know if it's relevant to this particular bill, but it is something that I appreciate you raising. My question is, what is the current process for training to be a lactation consultant? And then secondly, if you have, as you mentioned, if you're a woman who has resources and you use a doula, and a doula as a part of her services is being supportive to the mom to nurse, would this certification preclude someone like a doula from being able to provide that level of support if she chooses not to get certified?
To your first question, I do have information to provide to you in writing. I'll just run through the prerequisites. Okay. 8 college-level science courses, which are actually specified, 90 hours of lactation-specific coursework, 300 to 1,000 hours of supervised clinical care. All IBCLCs pass an international criterion referenced exam, which is given in 23 different languages in over 90 countries on the same day. We also must adhere to a code of ethics. We must have continuing education, and we recertify every 5 years. We must recertify by exam every 10 years. The International Board Certified Lactation Consultant has been described by the U.S. Surgeon General as the only allied healthcare professional certified in lactation management. In terms of a doula, this bill would not prevent breastfeeding education and classes. It addresses clinical care.
Okay, Representative Pack.
I'm the first one to go. I have 3 daughters, and my wife tried to breastfeed. She succeeded in a couple, and babies didn't take. My question is, it seems to me there's a lot of overlap of the services that you provide and currently existing medical professionals. Just given what I've observed, I had all my kids at Piedmont.
Mm-hmm.
Getting ready for the child, we went through an extensive training about new parents, and there was a long segment on breastfeeding by a lactation consultant hired by Piedmont, or she works at Piedmont. In addition, when the baby was born, the nurses certainly gave training on breastfeeding, in addition to the lactation consultant doing the rotation, coming to train and help my wife doing that. Then the other side, the concern that I have And I do think that the profession that you and your colleagues have is a very honorable one. It kind of echoes off of Representative Randall's question in terms of, are we really getting the benefit versus the cost of what I view as for creating yet another board and creating bureaucracy, which I think that many members on this committee has concerns about. We license virtually everything. The things that you rattled off, I think we should repeal them. I think many people would agree with that. And unfortunately, you guys are coming to ask to create the board and licensure later than those people who've done that. But what do you do in terms of help me understand what services and benefit that your profession provides in addition to what the other licensed professionals such as nurses to provide. And let's put it this way, and the other section is, it says here in this bill that you can't hold yourself out to be a lactation consultant and things like that. What about the freelancers? What I mean by that is a very experienced mother who had success raising a lot of children in the neighborhood, who'd go around and help, people that they know, help breastfeed. Would that person be now all of a sudden the board says, well, you're not licensed? Would that capture those type of people too?
You've got, like my head's reeling. Representative Pack, I've got, I think, three really important things that you wanted me to address. Sure. And if with permission, I'd like to bring up an OBGYN who can speak to one of the issues, which is the other doctors and nurses and how they play a role in lactation support. So I'll table that for just a minute. Volunteers, mothers, La Leche League volunteers are all exempt from licensure. So that, I think, addresses your last question about the sort of experienced mom needing to help her neighbor. There's some clear exemptions to licensure, which include the WIC program, employees of the federal, county, and state governments, volunteers, breastfeeding, education, and childbirth classes that are done by doulas and childbirth educators as well. So all of the good work those people are doing would continue unabated. But
okay, before you do it, I just want to know what a doula is. Pardon my ignorance. I'm not a bit of rant.
A doula, doulas consider themselves an extra pair of hands. It's a mother's helper. They consider themselves an extra pair of hands. It's a support person that sometimes helps a woman in childbirth. Dr. Fred Gober can speak about that because he has experience working with women who have hired doulas, and they also sometimes work with women after, just to help women transition to motherhood.
Okay, thank you. And
health insurance will help pay for it.
In some states? Okay, thank you.
Would it be okay to ask
yes,
Dr. Fred Gober, if you'll introduce yourself, to address your other question?
Welcome to the Health Committee. You've probably gotten a real...
Well, Representative Pack
well,
was asking.
just let him go ahead. Anything you'd like to say, answer Representative Pack's question, but also just if you'd like to, whatever else you'd like to impart to us.
Good afternoon, honorable ladies and gentlemen. My name is Dr. Fred Gober. I'm a recently retired obstetrician. That is, I delivered babies and took care of ladies for 36 years. I speak on my own behalf this day. However, I was representing the Medical Association of Atlanta. We went down to Savannah and had a meeting, and we had a lot of interesting discussions about these issues. I was fascinated by how we're taking such a simple concept and making it so complicated. This is a most highly trained, highly educated group of people we have in this area. I'm an obstetrician. I deliver babies. I'm not great at breastfeeding. Now, breastfeeding is not something to be taken lightly. It sounds kind of humorous and a lot of things associated with that concept. But the baby, if not properly, can get quite ill if not done properly. If they hit some of the cases they're going to present to you. you're not trying to stop other people from doing the things they do. You're trying to take the people who've shown the most commitment, training, education. You're allowing them to have established themselves as a subset that's available to physicians. Now, as a physician, if I refer a patient to someone, I have, particularly in OB/GYN, some liability. If the person is licensed, certified, there's a certain standard they've met. These are the people at the top. You're not trying to stop the people in the whole concept from doing what they do for a living. You're trying to incorporate the people at the top, as she said, encourage more of them, get them paid, and you have the concept that if you're referring a patient to these people, certain very high standards have been met. The practical point of view, obviously, is these small rural areas are not going to have these people. There's only so many of them to go around. It's a large state. So I was fascinated by how many discussions we had. I was one of the last speakers down in Savannah at the Medical Association of Georgia. And after I spoke, people seemed to calm down and focus on all they're trying to accomplish is this subgroup can be licensed, you know what you're getting, and you can use them. And that's all they're saying.
Okay, questions?
Yeah, was there a question that I was supposed to be trying to answer?
Michelle? I mean, Representative Hanson, who is it? Oh, Representative Barr, sorry.
Yes, sir. Thank you for coming. So let me ask a question as far as a rural hospital. What does this do? Do we now put a requirement on a rural hospital that they are now required to have somebody that is licensed? I don't know who the question needs to go to.
No, you can't do that. There's only a finite number of these people to go around. This is the top of people showing a commitment to this area of concern. Look at how the standards they have met are just incredible. There are no higher standards than they have. That's all they're saying is that they still can't get paid. People can't access them because they have to pay out of pocket. And all they're trying to do is get into a system where they can be paid and access more people and prevent more problems. And if I oversimplify this, they'll correct me, I hope.
The Rural Health Association is in favor of this bill, as is the entire medical community. May the AAP speak on behalf of it as well for a few moments?
Okay, Representative Barr, I would say to you, in rural areas, if someone could be reimbursed for this, and somebody that it might encourage them to go and meet all these requirements, to learn more, to become certified, so that the rural areas would have these highly trained people available. That, I mean, it could be a way to encourage them into rural areas. Representative Henson, just a second. Representative Henson.
I know we have two issues here. One is qualifications and knowing that the individual is met certain standards. The second thing that y'all have been referring to is cost. And yet you're stating that you generally see someone for an hour, maybe 2 hours or something like that in once. How much money are we talking about that is someone would be paying out of their own pocket if they come to see you, or whoever wants to answer this question?
Anywhere for an hour of care, the fees can range anywhere from $50 to $150, depending upon the market.
Thank you.
I think Representative Chokesley has a question for you. Wait. Okay, wait, okay.
I'm Susie Sizing. I'm here also with this group to speak just from the perspective of a mother who has used services of an international board-certified lactation consultant. And I have 3 children. My first child would barely breastfeed. It was a complete nightmare. I would have given up, but I had some services in the hospital, and I was continuing to have a lot of problems, and I went back for outpatient visits, and nobody could figure out exactly what the problem was. And it was a board-certified lactation consultant who said to me, "Your baby is tongue-tied. She needs her frenulum clipped. If it doesn't happen, she will never nurse." I went to the pediatrician, breastfed in front of him. He said, "I disagree. I don't think that's the case. You know, she's fine." Meanwhile, my baby's losing weight. She wouldn't eat. I really wanted to breastfeed her. I would have given up, but this woman insisted. I've seen this before, she said. I know your baby will nurse if you get the frenulum clip. Then it was a challenge to find an ENT who would do the procedure. We called all over the city on our own with no support. Everybody told me the baby had to be put under anesthesia. We could do the surgery in 3 months. You know, and your chances of breastfeeding, if you don't, you know, if you start to bottle feed formula for 3 months, you can't go back to breastfeeding. You know, she again, it was her experience. She said, I have sat with babies in doctor's offices on my lap, happened to be in the state of Florida where all her experience was. They clipped the frenulum, the baby nursed right after the procedure, and we walked out. There was no anesthesia. So we finally found a doctor who had practiced in another state. He said, yes, I've done that lots of times in the office. I'll bring your baby in. I'll see her tomorrow. If it's, you know, looks okay, there's no complications, I'll do it. He did it. We nursed in the office. I mean, it was a dream. But I continued. So I nursed that baby for 14 months. Never could have done it without the help of this lactation consultant. And she, you know, had the certification. She had a wealth of experience. She happened to be from Florida. She came in to see me specially, arranged through a friend. But I had 2 more babies. I had problems with all of them. Would have given up again, found a person here in Georgia, same licensure. She came to my home for months. I spent thousands of dollars. I was committed to doing it. I had a real conviction. Most people probably would not have gone through that, but most people wouldn't even have the opportunity to successfully breastfeed without access to those services. I came to the table with a lot of knowledge about breastfeeding already and the desire to do it. And I was lucky to have the resources and some friends to point me in the direction of where to find the help. But I think it's just critical. There's so many women out there who they do feel guilty because they couldn't breastfeed. I would have been one of them. I would have wished I could have done it, but I couldn't do it, and I would have just said, well, I just couldn't. But I could. I mean, I powered through it, but I needed the help. And there needs to be more access to those people that can provide those services.
Thank you very much for your testimony. Okay, Representative Tokus, do you have a question about where they get their training?
Thank you, Madam Chair. Where do you get your training, and is there a degree? Tell me more about your training before you become your specialty.
The health sciences courses could be taken at any college. They're regular health science courses. There are also now lactation management degrees. So people can obtain a degree, as far as I know, and there's other people here. I don't believe any of those degreed programs are offered in the state of Georgia currently, but there are online programs to actually get a degree in lactation management, which would include that coursework.
Leah, did you identify yourself? I'm sorry, aren't you an attorney?
So
Former
specifically,
attorney?
yes, I'm specifically, this is a second career for me. Someone told me I pivoted to my passion. I wish I did. I was a healthcare attorney for 8 years with Morris, Manning & Martin, and I'm currently a licensed attorney with the Georgia Bar as well.
Mm-hmm. Go ahead.
Yeah, a follow-up question. Now, when you say that these degrees, these courses are online and there are degrees available not in the state of Georgia, are they taught in the university? Is this part of a RN program? Is this just part of a liberal arts program? Is this part of a health science program? I'm curious about that.
Yes, I would be very pleased, if I may, to give you an entire list. I don't have it with me for today's testimony, of both the degreed programs and where they're offered, as well as the specific coursework that is required. And I'm happy to even do the research and let you know every Georgia institution that would offer those courses.
Thank you.
Mm-hmm.
Thank you.
Sorry, Representative Tokus, I think I can answer your questions about the RNs. When we used to be diploma schools of nursing and we would spend 3 months in each specialty area, we were taught breastfeeding techniques at the time. Now, because most of the nursing schools have gone to either a 2-year diploma, which even reduces the amount of time in the clinical setting, or to a baccalaureate program, and the clinical time is reduced greatly. There is practically nothing about breastfeeding except maybe reading it in a book and maybe seeing one or two breastfeeding mothers on the unit. There's just not the amount of clinical time spent anymore, and it's not the emphasis. For nursing, sure, for nursing.
I'd also like to share that there's clinical hours that are
That's what I was-
required, and that many women, especially in the rural areas, Representative Barr as well, are obtaining those clinical hours through the WIC peer counseling program. If their districts have WIC peer counselors, not all districts have WIC peer counselors.
That's what I was asking. I
Okay,
was
and the
about to ask
clinical
about the
hours can
clinical.
also be obtained through volunteer service with La Leche League, which is an organization that's been established for 50 years in the United States.
Thank you. Thank you very much.
Representative Randall.
Thank you, Madam Chair. At the proper time, I'd like to be recognized for a motion.
It has to go to Gork. I don't think we were really going to move today. I'll hear your recommendation. I mean, okay, they want to be heard today. Okay, hang on. Would you tell me what your recommendation is?
Oh, I certainly agree that this profession is very new, and there's people that can hold it, given the licensing, going through the licensing process for those that can't fulfill it, the opportunity to work with this profession, I certainly agree with that. Anything we can do to fix our staff of recruitment support and whoever else, I certainly.
How about a motion that we recommend to the Gork Committee that we seriously can, I take it you say that we seriously, that we think this is an important issue and that we stand behind it, and think about how you want to word that for a minute, and I think while we have somebody else, and we will.
Hi, I'm Arlene Toole. I actually work for the Georgia Academy of Pediatrics in Atlanta, Georgia, and I'm from Fayetteville, Georgia, actually, too. I just was, one of our pediatricians, our president, Dr. Wiskin, was not available to speak today. I've passed out his letter to you. But from a physician's position, he has 15 minutes with a new baby when they come in, 15 to 20 minutes. Their time limit is very short, so many physicians are wanting to hire lactation consultants. Actually, Dr. Wiskin does hire a lactation consultant at his practice, but physicians in the community, we do an education program for physicians in Georgia for OBs and pediatricians, and one of the things that pediatricians complain about is that I have a mom with a breastfeeding problem, I don't have time. So who do I refer to? Where do they get breastfeeding help? So we feel like having licensed lactation consultants available is going to help that situation. And actually, these IBCLCs or licensed lactation consultants do refer back to the doctor. They send their report or their assessment of the baby when they finish. So they have a very close relationship with the physicians.
Just a quick question, and it relates back to another one, but I noticed your requirements for being licensed by the board would say meeting the international education and clinical standards established by the IBLCE or other national testing service. Perhaps, I noticed somebody asked what were the requirements. Could we just get a list of the requirements that the IBLCE establishes?
We'd be glad to get you that.
All right, that would be good. Thank you very much.
I'm going to recognize Representative Randall for a motion. And go ahead.
Madam Chair, I move that this committee makes recommendation to GORC that we license this profession.
Okay. Do I have a second? I've got a motion and a second. Further discussion? Oh, okay, we've got a second. Any discussion? Hearing no discussion. Everyone in favor of this committee sending a letter to GORC recommending that they recommend licensure of this area, say aye. Aye. Anyone opposed, say no. I think the ayes have it. I think in that short period of time you've won this committee's support. Is there anybody else that is just dying to get up and would you like to say something, Ethan, about this? Okay.
Thank
So
you very much.
thank you to all of you coming. Thank you.